Hello, my name is Adam Sonabend. I'll be talking to you today about the phase 1/2 clinical trial of using a skull implantable ultrasound to enhance the delivery of Paclitaxel for patients with recurrent glioblastoma. This is work where I co-lead as PI on this trial with Dr. Rogers, to presenting on behalf of both of us. So I'd like to start just with the disclosures. First is the contribution of Dr. Stuck to all of these, and we are both co-authors on a patent filed by Northwestern University for this combination therapy. There's also support from this NCI R1 that I have, and in-kind support from Carthera and from Celgene. So I want to start by just explaining that blood-brain barrier disruption by skull implantable ultrasound has been previously demonstrated by Carpentier and colleagues in France. This idea uses a technology that is implantable, and therefore the sound waves do not need to go across the skull and be attenuated by the skull. As a result of that, the energy of the sound waves can be fairly low and still achieve pretty good blood-brain barrier opening. This is the first phase 1 clinical trial they did with a small implantable device where they show blood-brain barrier disruption with gadolinium. But since then, they have a second generation device that has 9 emitters all linked together on a mesh that is, again, implantable. So here are the 2 generations of device, the latest generation on the right, which is the one we're using for our clinical trial. You can see you can achieve a broader area of blood-brain barrier disruption. So this is the first implant we did in the United States as part of a different clinical trial involving carboplatin. You can see we excise a piece of the patient's skull in order to do surgery, and instead of plating it back, we screw in this device. You can also see it has an implantable a port that can be accessed percutaneously for activating the device. Here you can see a different patient of mine where the skull implantable ultrasound, it can be seen on this X-ray, and you achieve a very good broad blood-brain barrier opening that actually goes across dural layers and deep into the brain, achieving a large area of blood-brain barrier opening. So this is an example of one of my patients from a different trial, just to showcase the technology a little further. The patient has a pre-op scan showing a recurrent glioblastoma in the right parietal area. Post-operatively, you see a gross total resection, no enhancement in the periphery. And the pre-sonication scan done here shows no real enhancement in the peripheral parenchyma, but immediately after sonication, the scan is repeated, at which point you see a broad area of blood-brain barrier opening determined by gadolinium. The reason that we were motivated to do this clinical trial with Paclitaxel is that Paclitaxel is actually multiple log-fold more potent than either temozolomide or carboplatin for glioblastomas, as we've shown recently. It is about 1,400-fold more potent than temozolomide. So you need very little drug to kill the same number of tumor cells. On the other hand, Paclitaxel is as effective and as potent for low-grade gliomas and glioblastomas, at least at cell line level, as it is for breast, lung, and pancreatic cancer, for which is readily used. There have been previous experience using Paclitaxel in recurrent glioblastomas and in glioblastomas. So far, the systemic delivery of Paclitaxel has not led to any significant response. There was an interesting clinical trial where they did convection-enhanced delivery, and they had a 73% response rate, but there were several complications related to the method of delivery and the vehicle of this formulation used back then. More importantly, people had measured Paclitaxel concentrations in the peritumoral brain, and whereas it was somehow detected in tumor tissue, in the peritumoral brain in patients, this was not detected. So, Cremor bound Paclitaxel, Taxol, or albumin-bound Paclitaxel, Abraxane, are the 2 clinically available formulations of Paclitaxel. And what's interesting is that Cremor Paclitaxel is actually leading to a higher percentage of peripheral neuropathy, but they both exhibit this. And so we evaluated both formulations with regards to their pharmacokinetics and toxicity in the context of blood-brain barrier opening. And what we show here is that you can achieve higher concentrations in the brain using albumin-bound Paclitaxel than when you use Cremor Paclitaxel, as you can see here. You can also see that you have higher survival when you use albumin-bound paclitaxel in preclinical patient-derived xenograft models. And you can also see, because it's better tolerated, you can actually double the dose that you can use Abraxane relative to Cremaphore-based Paclitaxel, and we show overall survival improvements in different models. We have also shown preclinical model that when you sonicate a mouse brain with microbubbles and open the blood-brain barrier, you can let fluorescein to permeate, and when you co-inject Paclitaxel, the concentrations of the drug in the parenchyma are greatly increased, about 4 to 6-fold relative to non-sonicated brain, achieving levels that are actually therapeutic and in line with the IC50s for most human glioma cell lines. We've seen some modest survival benefit in these patient-derived xenografts. I think there's a great benefit from the drug. There's just an incremental benefit from the actual sonication. I think that is related to the fact that there is no real blood-brain barrier in these patient-derived xenografts. The tumor is not infiltrative, as you can see in this picture. We have also shown that the albumin-bound paclitaxel is way less toxic than the Cremaphore-based formulation. So you can see on this single treatment toxicity results, and over multiple course of treatment, it's once again shown to be much better tolerated. On the other hand, Cremaphore itself is toxic, even in the absence of Paclitaxel. Therefore, we attribute most of the neurotoxicity of Taxol to Cremaphore as opposed to Paclitaxel. So this data was the basis for motivating us to do this phase 1 clinical trial that has the goal first on the phase 1 to determine the maximum tolerated dose and a dose escalation regimen that will reach up to 260 milligrams per square meter, which is the approved dose for Abraxane or albumin-bound Paclitaxel, and determine also the DLT rate on this dose escalation. And then there's a phase 2 expansion cohort that will evaluate additional number of patients at the maximum tolerated dose, with the hypothesis that we will achieve a 65% overall survival at 1 year from enrollment. This phase 1 clinical trial has a point by ECN clinical trial design, which essentially leads us to redesign the trial after every patient finishes the DLT period. That way we minimize the number of patients that get treated at a subtherapeutic dose, and we accelerate the dose escalation while remaining safe. And we will have as many patients as possible to evaluate for possible efficacy on this early phase study. So the phase 1 clinical trial primary endpoint is clinically significant central nervous system toxicity related to Abraxane in the context of sonication with the ultrasound device on a cloud 9. The DLT period that we have involved for this starts from the day 1 of the first therapeutic sonication and finishes at the end of the first cycle. To date, we have been able to enroll 5 patients and implanted, and treatment was well tolerated so far. So it's a short discussion just to provide an update on our current clinical trial. This might be the most important slide in which I acknowledge the great support I have from several colleagues, the philanthropic support from Dan and Sharon Mosseri, the National Cancer Institute funding for this. Most importantly, the people in my lab were instrumental to this. Most of the preclinical work presented today was done by Daniel Zhang, who's now a medical student who spent years in my lab. And of course, my close collaborator, Roger Stoop. Thank you.